Can you appreciate these sternotomy wires? So if you see these are called sternotomy wires. If you see these types of wires, these are called sternotomy wires, and it means the sternum of this patient was opened previously. इसका sternum ओपन किया गया था. तो sternum जो है यूजुअली किस चीज़ के लिए ओपन करते हैं? मेनली फॉर द हार्ट. हार्ट में जो आपने काम करना हो तो वो ओपन करते हैं. तो उसमें फर्स्ट थिंग जो है वो कैबेज है. लेकिन अगर इस डायग्राम को अगर आप फोकस करो तो यहाँ पे आपको ये चीज़ मिलेगी. ये क्या है? दिस इज एक्चुअली एन मेटालिक वॉल. सो दिस पेशेंट अंडरवेंट मेटालिक वॉल रिप्लेसमेंट एंड दीज आर स्टर्नाटमी वायर्स. तो इसकी सर्जरी हुई है ओपन, और उसका जो है ये मेटालिक वॉल रिप्लेस हुआ है. सो यू हैव टू कीप एन आई ऑन ईच एंड एवरीथिंग. इसका मेटालिक वॉल. कैन यू अप्रिशिएट दिस अपर लोब डाइवर्जन, this reticulation, upper lobe diversion? This is called bat wing sign. These are the wings of the bat. So this is actually pulmonary edema. And can you appreciate this blunting of costophrenic angle? So the blunting of costophrenic angle, and can you appreciate the cardiomegaly? If you measure the exact size of the heart and you compare it with the total transthoracic diameter, this is actually more than 50%. Almost it is 60%. So if a patient is having metallic wall replacement, cardiomegaly, and a patient is having blunting of costophrenic angle and their reticulation and upper lobe diversion, normally vessels ऊपर की तरफ नहीं जाते. This is called upper lobe diversion. Vessels इस तरह जाती है. अगर आपको ऊपर की तरफ जाते हुए मिले ऊपर की तरफ, तो इसका मतलब ये है कि ये pulmonary edema है. So this is actually basically a pulmonary edema. So this is a CCF. This is a classic X-ray of congestive cardiac failure. Classic X-ray of congestive cardiac failure. So you should not miss these findings, especially sternotomy wires, especially the metallic wall, especially the reticulation, but upgoing reticulation, and the blunting of the costophrenic bilaterally. So this is actually a case of CCF secondary to mitral wall stenosis in the past, and this is bad.
So what do you see in this chest X-ray? If you focus on the lung volume, the first thing you should focus on mainly the lung volume. So this is less on the right side and more on the left side. Point number 1. Point number 2, the trachea is shifted to the right. Point number 3, over here you can see a triangular shaped opacity causing medial aspect of the diaphragm silhouette sign. Means you cannot appreciate the medial aspect of the diaphragm, and the most striking feature is absent of the hilum on the right side. Now what all these features suggest? Decreased lung volume, trachea shifted to the right, triangular shaped opacity, and absent hilum. This is right lower lung collapse. This is right lower lobe lung collapse, which is lung collapse is caused by any kind of obstruction. Let's suppose this is bronchus and this is divided into multiple branches. So if there is something obstructing this, what happens? The air is absorbed from distant portion and that become collapses. So we have to find out this thing, and this is find out by bronchoscopy. It can be cancer, it can be foreign body, it can be food particle, it can be secretion.
This patient presented with the chief complaints of shortness of breath, that is more on exertion. The patient is having ascites, and the patient is having tender hepatomegaly and bilateral period enema. Now what do you see in this chest X-ray? The most prominent sign in this chest X-ray is you can see over here this thing. You would not see this thing in a normal X-ray, and you cannot see this thing, this prominence over here, in a normal chest X-ray. Now when you see a normal chest X-ray, you are having aorta coming down, and then you appreciate the pulmonary trunk over here. So you can see a small depression on the chest X-ray. This depression is called pulmonary bay. Over here, this depression, that depression is obliterated by this thing. This is called positive pulmonary bay sign. This is called positive pulmonary bay sign, and the pulmonary bay is obliterated by this opacity. Now, what is this opacity? Normally, you can appreciate the aorta behind. This is the aortic line, and this actually over here is pulmonary trunk. So normally there is a concavity. When you see a normal chest X-ray, there is a concavity. So in this X-ray, the concavity is lost, and that is replaced by an opacity. And also, if you see over here, that is also the size of that is increased. This is called pulmonary arterial hypertension. This is a case of pulmonary hypertension, pulmonary arterial hypertension. The pulmonary trunk is dilated, and the descending pulmonary artery on the right side is dilated. So if you see pulmonary bay sign, this it means pulmonary arterial hypertension. Now that may be due to any cause. That may be primary or idiopathic pulmonary hypertension, may be secondary, may have 5 WHO classes. We will discuss in the next lecture the algorithm for pulmonary hypertension. But right now, you just focus on this chest X-ray with a positive pulmonary bay sign, and this is called pulmonary arterial hypertension. So pulmonary bay sign, this is a very important sign. You can miss this, but you should not miss this. This is a prominent pulmonary artery. We know that in the right hilum we are having arteries, veins, nerves, lymph nodes. But when you see pulmonary bay sign and along with that the bulky right hilum, this is actually a descending pulmonary artery. Thanks for watching. Do subscribe my channel and press the bell icon so that you can get notification of my new video. What is the best next step? Answer is echo with PAP, pulmonary arterial hypertension. That will show you PAP, pulmonary arterial pressure. Then for the etiology of PAP, what is the best next step? Look for ejection fraction, point number 1. Point number 2, look for pulmonary embolism and lung parenchyma. So you do chest HRCT, and then you do a VQ scan to exclude recurrent pulmonary embolism. Look for obstructive sleep apnea, obesity, hypoventilation syndrome. These are the causes for this case. Thanks for watching.
What do you see in this type of chest X-ray? Can you appreciate these wires? These are called sternotomy wires. These wires are called sternotomy wires. So it means that the sternum of this patient was cut and his chest was opened. The chest of the patient was open, as we can appreciate the sternotomy wires. What else you can see? Can you appreciate this thing? So again, this is actually a mitral wall replacement. So what is this? A double right heart border. A double right heart border. And what is this? Left atrial bulge. So this is actually the left atrium that is actually dilated. This is called the left atrial bulge, the double heart border, and the mitral wall replacement. So this is a typical picture of mitral wall stenosis, and the surgery has been done. The mitral wall is replaced, but it has got complications. The left atrium is enlarged. There is a right double heart border. So this is a pathognomonic for left atrial enlargement with MS. Now, what other abnormality can you appreciate? Can you appreciate the trachea? Can you appreciate the trachea? Can you appreciate the carina, the trachea and the bronch? Yes, over here you can see that the left main bronchus is actually lifted up. So the left main bronchus is lifted up. This is actually due to the left atrial enlargement. So it is compressing on the esophagus that leads to dysphagia. It is compressing on the recurrent laryngeal nerve, causing hoarseness of voice, and it is causing the elevation of the left main bronchus, so that the angle between the right bronchus and the left bronchus, that is more than 90 degree. That is more than 90 degree. So that was a typical X-ray. You can appreciate over here. The right double heart border is due to the left atrial enlargement. So in the left atrium, it enlarges